To give us an in-depth discussion on anxiety disorder, we have Dr. Ovidio R. De Leon. He is the head section of Neurology and Psychiatry, Gat Andres Bonifacio Memorial Medical Center, a fellow Philippine Neurological Association and Philippine Psychiatric Association, residency training in emergency and family medicine at Santo Tomas University Hospital, teaching and training positions in various residency programs of hospitals in Metro Manila. And on a personal level, may ninong. So colleagues, let us all welcome Dr. Ovidio R. De Leon.
Magandang hapon po sa inyong lahat. Allow me first and foremost to thank the organizers of this postgraduate course for the invitation and to thank all those who are here with us tonight. Thank you for sharing your time with us. So we were requested to um, do a lecture on the approach to mental disorders. And we chose specifically anxiety disorders because we realize that it is one of the most common cases that we see in the outpatient department. This was originally planned to be an interactive session, but because of connectivity concerns and limitations in time, we decided to modify it. What I shall do instead is to go through the topics and the decisions that has to be done and provide you with the rationale why such decision would be better off more than another. Um, but then in the end, I would be more than willing to answer your questions to clarify issues for the benefit of our participants. So without further ado, allow me to start with this case of WW, a 38-year-old female. She's single, she's Catholic, and she works as call center agent from Tondo, Manila. She came in because of hindi ko po alam ang nangyayari sa akin at hindi po ako mapalagay. The history apparently started in June of 2021 when the patient started to complain of non-specific chest heaviness. This was accompanied by on and off difficulty of breathing and palpitations. There was no fever nor cough detected. A consult was first made with her family physician, who, after examining the patient, decided to request for a CBC, a chest x-ray, an ECG, and an RT-PCR, considering that this was at the height of the pandemic. Fortunately, all the results came up negative. The patient was advised by the family physician and was prescribed vitamin C with zinc and was sent home. The condition apparently started after 2 weeks, or rather improved after 2 weeks, no? But there were still recurrences happening every now and then until October of 2021. This time, the patient came in with a complaint of epigastric pain with feelings of bloatedness and frequent eructation. The patient had loss of appetite, and because of this, she felt that she also had some weight loss. No? She came back for follow-up with her family physician, who then requested for an abdominal ultrasound and even an endoscopy. Okay. The patient came back with the result. The abdominal ultrasound was negative, but she was not able to do the endoscopy because she was afraid to go to the hospital to be exposed. Remember, she was afraid of getting the illness. The doctor prescribed her PPIs, which she took for 2 weeks. The symptoms again improved, albeit with recurrences every now and then, until December of 2021. Again, there were recurrences of symptoms, and this time accompanied by difficulty of breathing, accompanied by epigastric pain, and she suffered much with poor sleep. She felt all stressed out with these symptoms. No, being on a weekend, where all the clinics are closed, the patient decided to go to the ER for consult. The doctor at the ER saw the patient, reviewed the history, and did the examination. And then, in the end, seeing through the patient, decided to advise the patient, why don't you go see a psychiatrist? Maybe the psychiatrist can help you deal with your problems. Despite the hesitation, the patient came to a psychiatrist the following week, and the psychiatrist saw the patient found additional information. Number one, she had a lot of work-related problems. Remember, she was working as a call center agent. So one of her concerns was going to and back from work with getting exposed with patients during transport. Because of this, because of all her fears, she observed that her performance was declining because she could not concentrate enough to do the work. And when the supervisor noticed this, she felt that she was being harassed and singled out by the supervisor. Furthermore, the psychiatrist found out that two of her relatives suffered from COVID infection, and the added financial strain was too much for the family to bear. And with the fear that her declining performance might lead her to be taken out of the job, all these compounding reasons aggravated more the patient's anxiety. So, in summary, we had a patient who had on and off intermittent progressive cardiorespiratory symptoms with gastrointestinal symptoms on a background of a very anxious patient. Because of this, she had poor concentration. She was almost always irritable. She had sleeping problems and unable to rest. She felt almost tired all the time and wasted. Oh, if you recognize this picture, this is a picture slide of the comic strip Peanut. No? For the older ones in the group, I know you recognize them because they were very popular during the years past. No? Uh, I posted this because Charlie Brown, the primary character in the comic strip, is a patient with anxiety and depression. And if you remember, all her pronouncements, uh, dialogues were all related to fear and anxiety of things happening, and the world ending and him getting sick and all of that. You know? And the more important reason for projecting this is that every time we see a picture slide, that means a question is coming up. And uh, on your table, on your desk, and please have a paper where you can write down your answers. And what is the question? Okay, the question is, what do you think WW had? What do you think WW is suffering from? Okay, number one, do you think these symptoms can still be considered normal reaction? Or do you think the patient is suffering from one, panic disorder, two, somatic symptom disorder, three, PTSD, or four, generalized anxiety disorder? So is this still normal, or is there a disease entity that is happening on the patient? Dapat dito yung interactive session, you'll punch in your question so that we will see the results and discuss why you chose such. No? But then again, let me go through the discussion. Okay. So, when do we consider a symptom of worrying to be normal or already bordering an anxiety disorder? Okay, in normal worrying, cognitive aspect of anxiety is always worrying. No? In normal worrying, the worrying is short term, okay? And they can control it. And since this worrying is focused on one specific concern, for instance, fear of getting infection, the fear of getting infection is therefore grounded in reality because it's pandemic time. And therefore, the adaptive response is to avoid getting the infection by taking all necessary measures not to get infected. Diba? Okay. On the other hand, if the worrying, the cognitive aspect of worrying is now coupled with emotional and psychological reactions such as agitation, restlessness, inability to sleep, irritability, and all these symptoms. Therefore, hindi na worrying lang because there are other associated symptoms. And The history of worrying in this particular patient lasted for 6 months, long term na siya. And they were uncontrollable to the point of being like intrusive thoughts, no? Could not sleep, could not, focus on her job because the worrying is becoming too troublesome. And if worrying is focused in ordinary situations, here the worrying is generalized and vague. The patient cannot focus anymore on one particular topic, no? With the fear of being catastrophic, meaning everything is folding up or breaking down, no? And the most important part, the patient's function is impaired, so they cannot carry on with their usual activity. So if you have this kind of situation, then you realize this is not ordinary worrying anymore, but rather an anxiety disorder. The next question, therefore, is what type of anxiety disorder? Panic disorder kaya ito? What do you think? So the hallmark of panic disorder is that there is an abrupt surge of intense fear or discomfort that reaches its peak within minutes, no? So sudden burst associated with maladaptive change in behavior. So the patient becomes agitated, restless, would not know what to do, stand up and down, walk around like, like crazy, they say. No? And this is fueled by excessive worrying, no? That something is about to happen and that they don't have control over it. And this triggers more panic attacks. So, did we see that in this patient, in this particular patient, the sudden surge of intense fear? Doesn't seem so, no? Because the history was chronic, on and off, intermittent, although increasing, but never to the point of sudden surge of intense fear. So, mukhang hindi panic disorder, no? How about somatic symptom disorder? Okay. Ito yung category ng mga illness that was referred in the past were hypochondriasis or hypochondriac patients. Now, this somatic symptom disorder is a new category in the DSM-5, and the hallmark, rather the main symptom of this, is presence of a disproportionate and persistent thought about the seriousness of the symptom. No? So, for instance, the patient has headache, pero grabe yung concern niya about the headache, even if the headache has no other associated symptoms. Ang tingin niya, the headache is caused by a brain tumor. So there's disproportionate and excessive worry about the symptom. Despite the medical evidence showing no illness, dati, no illness. But now, they say even if you have an illness, but it is still not congruent with the concern or worry about the presence of that illness, meron kang migraine, no? May headache ka, meron kang migraine. But still, you worry too much thinking that it's tumor, that can still be considered somatic symptom disorder, no? Okay. And then, very important, no? The focus of the symptom is usually on one particular topic or one particular symptom, no? And the most common of all symptoms is always pain. Okay? Dito, the patient focuses on a lot of symptoms from gastrointestinal, cardiorespiratory, and the like. All of those symptoms, no, are scattered altogether. So, do you think this is somatic symptom disorder? Parang hindi, no? How about PTSD? Okay. So, classically, no, you remember PTSD as those soldiers who were in battle and then came back and suffering from PTSD after that. But actually, this disorder was originally classified under anxiety disorders, no? But now in the DSM-5, this is reclassified into another criteria, or rather grouping, which is called trauma and stressor-related disorders, no? What is the hallmark or the main symptom of this category of illness? There is and should be an exposure to one or more traumatic events. And that traumatic event can be an actual or a threatened one, death, serious injury, or sexual violence. So the patient must have been exposed to an actual or threat and serious enough to cause life, no? And as a result of the trauma, there are intrusive symptoms, no? The patient cannot control the recurrence of the thought. There is persistent avoiding stimuli, so they would avoid any place where there's too much noise because they might misconstrue it to be a blast or an injury, okay? And there's an alteration of cognition and mood with excessive arousal reactivity. So may pumutok o parang ano lang naman, nabagsak lang naman yung baso, but the reaction is severe startle na parang akala mo meron na nangyari, di ba? Those are hallmarks of post-traumatic stress disorder. And then, most important of all, with these symptoms, there is clinically significant impairment in social, occupational, and other areas of functioning. Kasi kung wala yan, it cannot be a disorder. So there has to be an impairment in your normal functioning that would call for something that is going on. Right? So do you think this is PTSD? I don't think so. All right. So then we're left out with generalized anxiety disorder. This is a very common disorder, but the main symptom here is fear or excessive uncontrollable worries. No? So aside from mental, yung cognitive function, there are physical symptoms or somatic symptoms like motor tension, restlessness, agitation, irritability. No? Di sila mapakali and all of that. And they are usually occurring with another comorbid psychiatric disorder like OCD and the like. Okay, the excessive worrying would have occurred in more days than none within a 6-month period. So in this patient, it started sometime in June and it's now like January when the patient came for follow-up. No? So the patient was suffering for 7 months. And aside from that, no, there should be 3 or more, at least 3 rather, of the following symptoms. So aside from worrying, they become restless, easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbances. So with these symptoms, we know that the patient suffering from generalized anxiety disorder, no? But you still have to make sure that there's no other medical problem that's causing it. What common problems do we think of? Thyroid disorders, renal conditions, and other medical conditions. Okay? Kasi you have to rule that out. And of course, there should be no substance use. No? Because then it will fall under a different category. Okay? So, in all likelihood, we think this generalized anxiety disorder, no? And I'm sure all of you will agree. There is a tool that you can use to assess patients, no? If they do have generalized anxiety disorder. And we have this GAD-7 anxiety score, no? This is a 7-point questionnaire that's self-administered, no? So while they're sitting in your clinic, you can give this paper around, or the secretary can do it for you, no? Give them around and the patient will answer it. So ang question is within 2 weeks, within the period of 2 weeks, did you have any of these symptoms? Often, several days a week, more than half the days of the week, or nearly almost every day, like anxiety, okay, unable to stop worrying, okay, trouble relaxing, being restless, and all the symptoms. So ito yung mga symptoms ng anxiety disorder. Okay. And then if the answer is any of the above, that you ask the patient and that the patient is asked if how much was it difficult to perform the usual activities because of the symptom. Not difficult at all, somewhat difficult, extremely difficult. Ibig sabihin, the symptoms are strong enough to impair the regular functioning. And if you get a score of 4 and below, minimal lang yan, no? If you get 5 to 9, it's mild, but anything above 10 is moderate to severe anxiety that needs to be addressed, okay? Now, if we apply the patient's symptoms on this GAD score, we totaled 16. And that means the patient has severe anxiety disorder. And you're right, she does. All right. Oh, I'm sure you recognize this character, no? Yes, she's Elsa from Frozen 1 and 2. Diba? Kilala niyo lahat yan. Especially the younger ones, no? Bago na mga Disney characters ngayon. No? So, Elsa, unlike all other Disney princesses, no, is an epitome or a metaphor of a mental disorder because in all Disney characters, they are usually brave, strong, and vibrant. No? But Elsa was suffering from anxiety and depression. Okay? And then again, why did we project this picture slide? Because there is a question coming up. And the question is, how would you manage now this patient? So Anong gagawin mo? If this patient came to you, what should you give your patient? A, would you give a benzodiazepine? B, would you give an SSRI? C, would you do psychotherapy alone? Or would you give them all at the same time? Okay, so write them down in your answers, please, and on your page so that we can go through them later on. So when we go to management, we used the NICE guideline. No? This is the National Institute for Health and Care Excellence that is renewed every 3 to 4 years with the best recommendations, no, in the management of neuropsychiatric disorders and other disorders for that matter. No? So specifically for generalized anxiety disorder, this is the STEP care model. Okay, I want you to look at the bottom first. Step 1 is at the bottom. So any patient suspected of having or presenting with GAD, what do you do first? Identify and assess, and then educate the patient on anxiety disorder. Hindi pa kagad maggagamot. So this should have been done on the first consultation. No? When you assess negative lahat ng mga findings, suspect of mukhang may anxiety. What can you do? Educate the patient about anxiety disorder and what can be done. No? But the more important thing is you monitor them. Ha? Kasi you have to ask them to come back for follow-up para makita mo kung kumusta na yung anxiety niya. Because sometimes you just have to, support them, give them information that would allay their fears and you will feel better so that you don't end up having the more serious stages of anxiety. If that does not work, step 2 therefore is when you have already confirmed the diagnosis na meron nga siyang generalized anxiety disorder. What do? Low intensity psychological intervention. These are mainly self-help activities, self-relaxation, advise them what they can do so that they don't build up the stress or tension and the like. Wala pang treatment, wala pang gamot, all psychotherapy. Okay. If on the third stage, again, the more important thing is follow them up. No? If on the step 3, third stage, the patient having had generalized anxiety disorder for some time now cannot or does not respond to the regular self-help activities and psychoeducation, then you start high intensity psychological intervention. And we're talking about cognitive behavioral therapy or other relaxation technique. At this stage, you may also start pharmacotherapy. And then finally, if that still does not help, then you call them refractory generalized anxiety disorder with severe or marked functional impairment. Here, you resort to high specific specialist treatment with multiple drugs and psychotherapy and group therapy and all the other possible regimens that we can offer. So, dapat may stepwise approach. Huwag kagad start of medication. Many can be arrested on the first and second step with proper counseling. Okay? But then again, of course, you can see patients who will progress in time. When we talk about therapies, there are two very important and most productive of all types. No? The cognitive behavioral therapy and mindfulness-based therapy. No? Sa cognitive behavioral therapy, yung cognition is seeing and helping the patient to control those thoughts that support fear kasi yung thought na yon will fuel the fear. And then the behavioral component is modifying the reaction to stimuli so that they don't precipitate that. Okay? This is a process that needs to be handled by well-trained psychotherapists. No? How about mindfulness-based therapies? No? Ito, very important and very useful. In mindfulness-based therapy, you focus on the present, here and now. No? What is the source of anxiety? You worry kasi last time you were not able to submit all the papers that you needed to. Kaya ngayon, naghahabol ka, you feel anxious. Paano na bukas? Pag hindi mo na i-submit, baka bumagsak ka. Parang ganun. So what do? You focus on the present time, here and now. Do everything you can do at this present time because you cannot do anything about the past, nor should you look forward because you don't know what will happen in the future. But if you make sure that you do the best you can in all your activities in this present time, then you can be assured that you'll have a better future and better opportunities in time. All right? Good. Okay. So, however, if you reach the stage where you will need treatment, pharmacotherapy, the recommended is the use of selective serotonin reuptake inhibitors. And these are the list of the SSRIs that we have in the market today, except for fluvoxamine at the bottom, which was pulled out just before the pandemic, a few months before the pandemic. Now, all the other SSRIs in the list are present and available within your reach. Okay. Next, if the SSRI did not work, no? If the first SSRI is ineffective, offer an alternative SSRI or an SNRI. And this here shows the list of the SNRI that's available to us. Duloxetine, venlafaxine, and desvenlafaxine. Okay, now this is a table that tells us the proper dosage of the SSRIs and SNRIs that's available to us in the market today. Okay, so you can take a picture of this so that you can remember them. No? And on the third column, look, FDA approved for anxiety disorder. What specific disorder? The escitalopram is specifically approved for generalized anxiety disorder. No? And most of the SNRIs, two of them are approved for generalized anxiety disorder. But then again, if you look at the off-label use of the other drugs, look, they all respond to, they're also used for general anxiety disorder, social anxiety disorder, panic disorder, and the like. So in essence pala, whatever our diagnosis in the first, no, if we see that the patient is suffering from, you can use any of these drugs, no, and see with your follow-up and monitoring if they would respond to the drug. Now, what should your choice be? What is the best antidepressant or SSRI for the case? Actually, there's no specific one. You just have to choose which one is appropriate for your patient. For instance, if you look at the cardiac conduction disturbances, okay, escitalopram has a mild effect as well as venlafaxine. No? Therefore, if you have an elderly patient, baka ayaw mo gamitin yan kasi baka magkaroon ng cardiac reactions. No? How about hypotension? No? The SNRIs are at risk of developing hypertension. Kaya baka hindi ka gagamit ng SNRI pagka meron kang patient na mababa ang blood pressure. Of all these drugs, which one is sedating? Almost all of them are non-sedating or mildly sedating. Therefore, you can use them actually in the daytime. No? The other sedating drug like fluvoxamine, not in the market anymore, paroxetine is you may use at bedtime para pati sleep nila mag-improve. Okay, what do all of this have in common? Nausea and vomiting. Okay, all of them will have none. That's why we are recommending that you start the medicine low and then go slow. So you start, like for instance, escitalopram, 10 milligrams. You start with half a tab in the morning for the first 1 to 2 weeks before moving up to 1 tablet. Okay, I've seen other psychiatrists who started with 1/4, no? And then going on to 1/2 and then 1 whole tab. How about sexual dysfunction? Well, almost all patients with anxiety disorder do not usually think about sex. No? So maybe when they start asking about sexual functions, that's a good sign that they're already improving. No? So you may act accordingly. Okay. So to 1.2.4, if the person cannot tolerate either an SSRI or an SNRI, you can consider pregabalin. Okay, so pregabalin we use more for neuropathic pain, di ba? Pero they have anti-anxiety actions, no? But you have to remember, very sedating yan. So just be careful when you start them on that. Okay. To point 25, do not offer a benzodiazepine for treating generalized anxiety in the primary or secondary consult, except if you use it only a short term and in state of crisis. So pag crisis, you may, no, but make sure you pull them out soon enough, no, para they don't get used to it. And then lastly, do not offer an antipsychotic in the treatment of generalized anxiety disorder in primary care. You only use these types of medication when you reach the stage 4, no? when they are all complicated with a lot of other associated symptoms, then you may use these sorts of medication. So let's go back to the patient. Uh, what was given to the patient instead? Okay, so the psychiatrist who saw the patient decided to start the patient on escitalopram. So nag-SSRI siya. He started on 5 milligram tab, that's half of the 10 milligram, no, for the first week, and then advised the patient to increase it to 1 tab on the second week. Okay? Together with that, the psychiatrist decided to put alprazolam. So nagbigay siya ng benzodiazepine, ha? Pero low dose lang, 0.5 milligram per tab, twice a day, with the plan to withdraw it when the patient comes back for follow-up in 2 weeks' time. And then, of course, the psychiatrist started supportive psychotherapy and psychoeducation to allay the patient's fears. Okay? Ang mahalaga, the doctor asked the patient to come back after 2 weeks. So that should be the 4th week of January. So, ano nangyari? Okay? So, nung uminom na yung patient ng escitalopram, the patient felt that there was palpitation. So, she decided to stop the medicine, no? After 2 days. However, when she recalled what the psychiatrist told her, that there might be some exacerbations of symptoms in the early stage of the treatment, but continue on, no? They will all disappear in time. Don't worry. It does not mean that your illness is getting worse. It's just something that you have to adjust in the course of the treatment. So after 2 days, the patient decided to resume the escitalopram and alprazolam. And the patient continued the treatment until the next follow-up. So then came the first follow-up. The patient was supposed to come on the last week of January, but came on the second week of February. But she was still taking the meds, okay? So what happened? The patient is more comfortable now. She's less apprehensive and with less palpitation. So nagpa-produce na ng effect yung meds. No? Patient still has occasional epigastric pain and discomfort, but they're generally tolerable. No? The sleep was better, maybe because of the benzodiazepine, no? And the appetite was also improving. So she also was able to concentrate more at work. So nag-improve na. However, she still felt that she'd prefer more to stay in the room. And whenever there are concerns, no, she would still call on her siblings when they come late, coming from work or from school. No? So merong nag-improve, merong hindi. But in general, if you weigh the symptoms, the patient feels that she is improved already. All right. Oh, a picture slide ulit. Okay, picture slide. This is the famous painting of Edvard Munch, a Norwegian painter who himself suffered from anxiety and depression. Kaya ang mga paintings niya are depicting of an illness, no? And this is his depiction of anxiety. But more importantly, this slide means there is a question coming up. And the question is, ano gagawin mo? Okay, 1, should you continue escitalopram? So the premise is the patient improved with 10 milligrams per day, but there are still negative symptoms. No? Meron pa siyang mga symptoms na natitira. So the question is, would you continue at 10 milligrams per day? Or B, would you decrease escitalopram 5? After all, nag-improve naman na siya. Okay? C, would you increase the escitalopram to 20 milligrams? No? Kasi may natitira pa siya symptoms. Or D, would you consume the escitalopram? And then another option, should you shift to another antidepressant? Okay. Shift, nag-improve eh. No? So baka you need to give the patient a little more time para lalong mag-improve. No? So, what can you do to predict response of treatment? No? What should you look out for you to predict response to treatment? So, there is greater likelihood of response if the symptoms are shorter, meaning hindi umabot ng ganun katagal, no? And the absence of other psychiatric comorbidities. Wala na siyang depression, walang other disorders, but only the anxiety. Okay? And there is no history in the family. So, ibig sabihin parang there's a better chance for them to get better if they don't have any of these symptoms. The other clue is that if there is improvement or onset of the efficacy happens within the first 2 weeks of treatment, that's a very strong predictive indicator that the patient will go into remission. Gagaling yan, no? Kasi first 2 weeks pa lang, positive na ang response, no? So, they are most likely to go into remission eventually, no? However, if after giving the medication 4 to 6 weeks, the patient has not shown any significant improvement, oh, that's a bad sign, no? That's a bad sign that the patient will not respond to treatment or will go into recurrent symptoms in the future. All right. Furthermore, if the patient came back to you but did not improve, what are the things that you should look out for? Number one, check for adherence first. Iniinom ba talaga yung gamot? Baka hindi, di ba? And therefore, when you ask the patient to come for follow-up, kailangan ask them to bring somebody with them para you can ask if the medicines are being monitored kasi they can refuse to take it, but if somebody is monitoring them or helping them with the medication, then you can be assured, no, of compliance, no. O umiinom nga ng gamot pero nadagdagan naman ng stressor kasi nagka-COVID siya o kaya may relative na namatay or from the illness. So an increase in the stressor can cause aggravation of the symptoms or non-response for that matter. O baka naman may substance use patient, no? But then again, if all of these are canceled out, umiinom talaga ng gamot, hindi naman nag-increase ang kanyang stressor, and yet, no, wala namang other substance disorder, and yet hindi nag-improve ng patient, baka ang problema yung doktor, no? So we have to check our diagnosis. Baka mali ang diagnosis natin kaya hindi nagre-respond yung patient. So you might have to review the symptoms again. Okay? And then, if indeed there was no response to initial treatment, anong recommendation? One, you should increase the dose of your antidepressant. You can switch to another evidence-based pharmacotherapy, that's another SSRI or an SNRI, or you may augment with another psychoactive drugs, no? In this case, pwedeng benzodiazepine or mga antipsychotic agents, or you can always combine them with psychological treatment. So may psychotherapy together with it. So let's go back to the patient now. So what happened to our patient, no? So nag-improve siya pero may natitira pang symptom, no? Anong ginawa ng doktor? So after discussion with the patient, sinabi ng doktor na nag-improve ka na pero may konting symptom pa, the doctor decided to increase the escitalopram to 20 milligrams. So yung increased dose is based on the recommended dosage of 10 to 20 milligrams per day, no? To make sure that all the symptoms will improve, no? And was asked the patient to come back after 3 weeks. So that should be the first week of March to see if the patient has indeed improved and gone to remission already. So, anong nangyari? No? Anong nangyari? Well, the patient came back for second follow-up. Instead of first week of March, dumating second week of March. Okay, late na naman siya. Pero mahirap daw kasi mag-schedule ngayon kaya delayed. No? Anyway, tinuloy pa rin niya yung gamot. So, the patient feels so much better. And then with the completion of the vaccination and having had the booster, mas nagkaroon ng confidence yung patient na hindi na siya basta-basta mahahawa o magkakasakit. Although they were back to face in their work, mas confident na siya. And according to the sister, the patient is back to her normal self na daw. Normal self, no? This is barely 2 months in the treatment. No? The patient is very grateful to the doctor, okay? And now, the patient popped up the magic question. Sabi niya, Doc, pwede ko na bang itigil ang gamot? Okay. Oops, picture. You know this picture very well, di ba, no? This was painted by Van Gogh, and what many do not know is that this picture is from a view in his room while he was confined in the asylum in Saint-Rémy, France, no? This was a mental institution in France where he was confined. You know why he was confined? He cut off his earlobe, and that triggered, no, for him to be confined. So he suffered also from depression. And in one of the windows in his room, this was the view. So he painted it. And they thought that at that time she was also improving already because there were some improvement in the colors already compared to the earlier paintings she's had. Again, the picture slide says there is a question coming up, and the question is, will you accede to the patient's request? Doc, titigil ko na ba yung gamot ko? Pwede ko na bang itigil yung gamot ko? Should you consume escitalopram? B, should you just decrease it from 20, gagawin mo 10 na lang? Or should you advise to continue the treatment? Kasi 2 months ka pa lang. Remember, no? 2 months ka pa lang sa treatment. All right. So what does the NICE guideline say? No? It says, you should check the effectiveness and the side effect of the drug every 2 to 4 weeks within the first 3 months. So you should ask the patient to come back every 2 to 4 weeks within the first 3 months, but every 3 months and then every 3 months thereafter. Okay, remember, patient, no? And then if the drug is effective, advise the person to continue taking it for at least a year because of the high relapse rate. So, ang tanong, pwede ko na bang itigil ang gamot ko, doktor? Anong sagot? Okay, anong ginawa? Sabi ng doktor, no, you have to continue your medicine, no? And continue to take 20 para tuloy-tuloy ang paggaling mo kasi nasa second month of treatment ka pa, no? It will take longer for you to have full remission and so that we prevent the recurrence of the symptoms. So, tuloy mo lang yung gamot mo and then come back on the first month, second week of April, come back after 1 month. This should have been the third month already of treatment of the patient. Okay? So, pumayag yung patient, umuwi na siya. Okay. And then, came April, first week of April, dapat, no? Dumating siya fourth week of April na. Okay. And what happened? The patient was brought this time by her fiancé. Okay? Hindi na yung kapatid ang nagdala, yung fiancé na. And then, eto, sabi ng fiancé, Doc, we're planning to get married in June. Okay. Therefore, we decided to discontinue the medicine in the second week of April kasi we were afraid na magkaroon ng side effect kung siya ay magpe-pregnant. Right, so ito ang dilemma natin, no? Medication, pregnancy, and remission or recurrences. Okay, ano pa nangyari? Okay, in the fourth week of April, remember, she stopped the medication on the second week, you know? In the fourth week of April, the patient was noted to have difficulty sleeping again, and there was gradual and progressive decrease in appetite. Then she also started complaining of a lot of things about work, not completing her task, difficulty of focusing, and unable to complete all the requirements. No? And then, because of this present concern, the patient now started worrying again that she might lose her job because of poor performance. And therefore, if she loses her job, she will have financial problems and they would not have enough money for the planned wedding come June. Ito na, nagwo-worry na naman, bumabalik na naman dahil tinigil ang gamot on the second week of April. Okay, so if the patient came back to you, what are the things that you should look out for in your follow-up care? Okay, remember that anxiety disorders are chronic illnesses and therefore would wax and wane. Wax and wane. Huh? Your objective or our objective should be to have full remission of symptoms to pre-morbid state before they had the illness. Hindi pwedeng improvement lang kasi we are preventing remission. All right? So we should go for full remission of symptoms, no? So therefore, continuation of the antidepressant beyond initial response, which is improvement, no, must be continued so that we prevent relapse. And evidence-based guidelines recommended that at least 6 months of continuation treatment after the initial response. So the initial response is usually seen within the first 3 months, and then it recommended 6 months of continuation after this. So that's about 9 months. Kaya ang recommendation is 6 months to 1 year of treatment. All right? Okay. How did they come about with those recommendations? This because of this risk of relapse study. This is a meta-analysis of relapse among patients who were maintained on antidepressants, SSRIs, no, who were suffering from anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorders, no? And they studied what happened to them if they stopped their medication. Okay, general data showed that 1/3 of patients with antidepressants will cause a relapse after discontinuation of the drug. 1/3. Madalas, no? However, even if they continue the drug, 1 of 6, meaning 15%, will still have a relapse despite continuing the medication. But if they continue the medication, 1/3 lang ang magre-relapse. So, maintaining the medication reduces the chance of relapse, no? And this data is supported by further studies and meta-analysis that if you continue the SSRI, you prevent the chance of recurrence. Okay? So again, what was recommended, no? Review the effectiveness and the side effect of the drug every 2 to 4 weeks, 2 to 4 within the first 3 months, but follow the patient up every 3 months thereafter until you complete the course of 6 months to 1 year. Okay, if the drug is effective, advise the person or the patient to continue taking it for at least a year to prevent relapse. So what happened to the patient, no? The patient was advised to resume escitalopram, no? Paano yung plano? Magpapakasal sila? Di pwede kasi pag nagkaroon ng psychiatric disorder ulit yung patient, you can just imagine how their life will be. So, you have to educate the patient, including the fiancé, and then advise them. Kailangan po ituloy natin ito. And how should we start it? Start low again and then increase to the proper dose. So this time, the patient was advised to start with 10 milligrams and then take one whole na after 2 weeks onwards, and then to come back for follow-up after that. Okay, how about the fear of the patient of getting pregnant and then eventually of nursing, no? So there is, in a large national survey, a study that looked into the prevalence of anxiety and depression among patients who are single and who are on the family way. And they found out that there was no difference. Pareho lang ang anxiety and depression in patients, in this group of patients. And that the worry about teratogenicity can be addressed by the following study. Okay, there was a Swedish medical birth registry that looked into 4,000 mothers who were on SSRI or SNRI during their pregnancy. And what was found out? There was no apparent risk of teratogenic effect of these drugs if they are maintained in the therapeutic dose. So, if you maintain on the dose, there's a likelihood that they will be able to carry the pregnancy in time or in full course, and that there should be no risk of teratogenicity. But this is a decision that you cannot do on your own. You have to talk to the patient with this, and they should concur if they should continue taking the drug or not. For me, if they decide to go with it because they are concerned about health, I would allow them. If they decide, however, Doc, mas gusto ko magka-baby and ayokong ilagay yung baby sa risk, and I would decide not to take the medicine, it's all right. That's their decision. But the most important thing, if you told them what to do and then you just ask them to come back for follow-up, para you can do psychotherapy and support the patient while they carry on with the pregnancy, right? How about nursing mothers? Okay, yes, the SSRIs and the SNRIs can pass through breast milk. However, they were found to be at very minimal concentration so that there was no adverse reaction in the baby who were exposed to SSRIs. No? Hindi naman naging hyperactive yung mga baby, kaya okay lang naman sila. Alright? So, what actually happens in patients with anxiety? When something good happens, they think that something bad will follow. And if something bad happens, they think that something worse is going to happen. Parang they cannot really take out that worry in themselves. They're always overthinking. No? So, in summary, therefore, okay, You have to remember that GAD is a very common disorder. In fact, has become more common because of the pandemic. The main symptom is fear and anxiety, which are uncontrollable. No? Aside from the mental aspect of worrying, there are somatic symptoms: motor tension, restlessness, agitation, irritability. And all of this is brought about by the excessive worry. No? Most patients who have GAD also have other comorbidities. So some have depression, some has panic disorder, and OCDs. No? The treatment includes psychotherapy first, and then pharmacotherapy, and a combination of both. When you talk about pharmacotherapy, you talk about SSRI or SNRI. And the recommended treatment, length of treatment, is at least 1 year to prevent relapse. All right. So I hope this would help you in your decision making when you handle patients with this disorder. And I end with this slide. Pagkatapos madinig ang lecture, kaba ka ba? Kaba ba? Maraming salamat po sa inyong lahat.
Thank you po, Doc Obi, for sharing the journey of WW to us. So, continuity of care po talaga. Thank you also for the doctors who answered the questions in the slide. So, we are now open for Q&A. So, we will be entertaining 1 to 2 questions. Great lecture daw po. Thank you. Puro pasasalamat po, Doc. Usually, Doc, sa clinic po, what we encounter are, especially now in times of COVID, yung mga sleep disorder as part of anxiety. Di sila makatulog.
Yes, yes.
So,
Thank you, Dr. Ren. And thank you for all those who were actively answering the questions. I did appreciate that a lot. So, like you said, Nanet, sleep disturbance is a common symptom, but they are not the disease in itself. It is usually a part of a greater problem. Like for this instance, it's the anxiety, and for some, it's from the depression and all the other associated symptoms.
So we try to address the primary disorder. May give short sedative agents, but only for a while. Because if we treat the primary problem,
even the sleeping symptoms will eventually improve.
thank you po. Can we give melatonin for patient with anxiety and is taking escitalopram? From an anonymous attendee po.
Okay. There is no real contraindication to give melatonin, but it should just be an adjunct. Okay, you still have to go through with the recommendation, which is an SSRI or SNRI. Okay, the recommended for melatonin is 3 to 5 milligrams at bedtime, but only for short courses.
remember, there's no real problem with melatonin. It is the anxiety that's causing the problem, not because of some problem with the melatonin.
For primary care, do you recommend giving SSRI for patients with GAD immediately as first checkup? What SSRI would you recommend po as first line?
In the process of analysis, if you can do
Initial
psychotherapy and psychoeducation, you may hold back your SSRI. But if at the first consult they are already in crisis, and maybe because they've been trying to hold back the symptoms for a long while, I think there's no reason why you should not start right away.
But
Most importantly, you tell them
you might have some exacerbation of symptoms at the start, but don't worry,
it's all going to improve in time. Just continue on with the medication.
So yes, I would agree. Give right away if you feel
it is needed.
So, next question po, how to help the patient to identify the primary cause of their anxiety?
That's what I appreciate in Family Med. Kasi you know them already, ano? Alam niyo yung family history nila, alam niyo yung cause and problems sa kanilang situation. So, it's easy for you to identify what the risk factors are. So if you do that, I think you counsel them on the cause of the problem, and then adding on your biologic treatment with it, I think you're gonna get it easily.
Last question po, for grade schoolers who started having anxiety, can we start escitalopram 5 milligrams?
Pwede po. There are studies now, especially on children, especially during this pandemic, no? Young kids developing anxiety. If you need to, you may. Okay. But you need to get a more complete history of the patient, and sometimes the parents have a lot of things to do with that. You know, parents pressuring their kids to perform and monitoring all their online projects and exams. So you have to talk to the parents also. Baka sila yung dahilan, no? Okay. And what's the most important in all the advices? Make sure you follow them up. Don't hesitate to ask them to come back in 2 weeks, every so often within the first 3 months. Our objective is to abort progressive illness to reach stage 4. If we can do 1 and 2 and resolve them, we must have succeeded already in our objective.
Thank you po. Thank you po, Ninong Doc. So,
Thank you. Salamat po sa inyong lahat. Thank you.
We will award po the certificate of recognition. Ma'am, kindly flash po.